reviews of all of our maternity and neonatal services across the 8 providers. And we have a learning event on the 2nd of February to see what was best practice and share across the system. There was nothing flagged up particularly from those visits, but we have conducted a peer review visit of the Newcastle hospitals in relation to their Embrace data and them being an outlier for infant mortality. Now, that Embrace data does look at all providers who provide an level 3 neonatal unit with surgery, so they are very different across the country. And there are only a small number of organisations who undertake congenital work, and Newcastle being one of those. But even if we take out its congenital work, it is still a 5% outlier. We are doing some work with Embrace nationally to compare like with like. So we're looking at ensuring that organisations like Leeds, Sheffield, Manchester, we compare them to each other. But following the meeting that we've had in our peer review, we are going to do some joint peer reviews with Leeds and Sheffield, just as a comparator. The 3 areas that we found on that review that needed immediate attention, one was around they have a bay in the unit which had no emergency call buzzer. So that was flagged straight away and mitigations put into place. We are confident that the mitigations manage the situation. There is something around their governance processes in terms of SI reporting, and we're doing an independent review of that. And then finally, staffing. So they do have staff in place, they're over-established, but it is the level and competency of some of those staff to manage the situation. They have 38 cots in Newcastle, and they were supposed to open an additional 4 in October due to pathway changes from South Tyneside and Sunderland Trust. They haven't been able to open those beds yet, those cots yet, but there is a plan to open those in January. So we're working with the Trust in terms of its workforce plan.
Thank you, David. Anybody want to raise any questions or points with David? No, thank you very much then, David. And move on to the Chief Executive's report from our Chief Executive, Sam Allen.
Thank you very much, Chair, and good morning, everybody. I just want to start by saying it is a real privilege to be appointed as Chair of the National Maternity and Neonatal Programme Delivery Board, and delighted to take up that responsibility. I will chair the first of those boards next month, and we'll be working closely with the team delivering the 3-year delivery plan at NHS England for maternity and neonatal services. I'm really looking forward to taking an improvement approach to that programme. You will have seen that a significant amount of the work is around the culture of services, but also working very closely with families and also clinicians and professionals working across those services. That is an additional responsibility I'm going to be doing alongside my role here in the ICB. It has been an incredibly busy time for services. In spite of the weather just starting to dip in temperature, we have seen a noticeable increase in demand through our acute and emergency services, and indeed that would have been felt by general practice and of course our voluntary and community sector partners as well. I'm pleased over the last day to hear that there appears to be progress with regard to industrial action, which, as you'll be aware, has been paused to enable talks to happen. And I was pleased that NHS England were able to allocate out to systems additional funding to meet the cost of that industrial action over the past year. And like all of the other 41 ICBs, we've been working very hard with all of our NHS trusts over the last couple of weeks to revisit our plans, particularly for urgent and emergency care, but also our financial plan. You will know that this year we agreed a deficit plan with NHS England of just under £50 million. We did meet with NHS England yesterday to present the work that we've done over the last couple of weeks, and indeed we held an extraordinary board meeting as requested last week to sign off on a revised financial forecast for this year, which has been agreed as a £35 million deficit. So with the additional money coming into the system, we do feel that we can improve our financial plan this year. We will continue to work hard, and where we can strive towards a break-even plan, we absolutely will do. However, we think it is realistic of us to agree that £35 million deficit plan, and that's has been supported by NHS England, and our finance Director, David Chandler, I'm sure will comment later on in his finance report on this, Chair. Alongside the revised financial plan, we were issued with very clear guidance that the priority, certainly over the next few months, has been to prioritise urgent and emergency care, and also the elective recovery plan and cancer care. While still above the national trajectory on cancer, we certainly have more to do in that area, and we indeed have more to do if we're to hit our ambition of having 0 78-week waits for elective care and reduce the number of people waiting over 65 weeks for elective care. It'd be fair to say we have continued to make progress in those areas, but it has been impacted by the industrial action, and Jacqueline Myers, our Director of Strategy and Operations, will certainly cover some of that through the integrated performance report. Alongside all of this, again, like other ICBs, we are in the midst of our running cost reduction. So that target for us was reducing our running costs by just under £18 million. And we are out to consult with our organisation at this point in time on revised structure. And that does include fewer jobs than we have today across the Integrated Care Board. We are taking this opportunity, particularly on the back of bringing the ICB together from 8 predecessor organisations, also to address issues around equity, reduced duplication. Notwithstanding that, this is a significant change, both for our staff and also our partners that we work with. So we will continue to support our staff through this process, and also reduce, insofar as we can, the likelihood of any compulsory redundancies. It would be also remiss if I didn't mention the impact on our commissioning support unit, the North East Commissioning Support Unit, who are also out to consult with their staff to reduce the amount of support we give them by 30% as well. We are working closely with our staff side chairs. I do just want to note that we have participated this year for the first time in the annual NHS staff survey. That survey has been undertaken in the midst of this significant organisational change, and I do anticipate when we look at the results next year that we'll see that reflected in the results and feedback from our staff. We do continue to support our staff through this, and we do have a variety of support package in place for our staff, including access to employee wellbeing support, coaching support, and also personal advice with regard to careers and coaching. I am confident that we will deliver the national target for the running cost reduction. However, we also will have to embed our new way of working right across the ICB, and that will take some time. I'm delighted, Chair, that we have got our system leadership group off the ground, and that meets formally for the first time this week. We have undertaken work as a group of system leaders working in health and local government over the last couple of months, supported by Sir David Pearson, and that's been well attended by partner members, and our VCSE partners will also be represented in that system leadership group. The 3 areas that we've agreed that we will focus on working right across North East North Cumbria will be children and young people, including children in poverty, system leadership, so supporting leaders right across public services here in North East and North Cumbria, and also the opportunities that we have on our workforce. And we do have our workforce strategy in draft, nearing completion, and we'll be considering that at our meeting this week. There's been some changes in our system, so we have one new chief executive appointed for the Teesside group, North Tees and Hartlepool, and South Tees Trust, and Stacey Hunter will join the system from Salisbury at the end of January. Stacey has already been spending time in both of the organisations getting up to speed, and she will be the single chief executive working with a single chair across both those organisations. We look forward to welcoming Stacey, as I know our provider collaborative will do so too. And colleagues will know that Sir James Mackey, the current Chief Executive of Northumbria Trust, has been appointed to take up the post in Newcastle, and Northumbria are interviewing for their Chief Executive post in December. I do, Chair, just want to touch on our two foundation trusts, particularly from a CQC perspective. The Newcastle upon Tyne Hospitals NHS Foundation Trust is, as we've reported here previously, we do have a quality improvement group in place for oversight of the organisation. The deadline for submission of the Trust comments on their draft CQC report is today, so we hope in the next few weeks to get an update on when the publication of the CQC report. We do know that the Trust has had their rating suspended. When that happens, it is a strong indicator of the likelihood that there will be a change, significant change in the rating of the organisation. And we know that this is an organisation that's been rated outstanding for the last several years. We do meet with the Trust regularly through a formal quality improvement group that I chair. We have oversight of all of the actions in place across the organisation, and we're working closely with the NHSE regional team, the Trust Board in Newcastle Hospitals Trust. So James Mackey is the incoming Chief Executive of the organisation and the CQC. I was pleased to see the Tees Esquire Valley CQC report published and the notable improvements that they have made since the last CQC inspection. Whilst they're still rated requires improvement, there were a number of improvements that are noted within the report. There are also areas that require ongoing attention, and the one area I do want to particularly highlight, Chair, it's included on page 5 of my report, and in fact there is a slight typo in the report, series should read serious, was the backlog in serious incidents at the Trust. I know the Trust understand that that's unacceptable. It has been unacceptable. They have been working through that backlog of serious incidents with the support of the ICB and the regional team, and we have had a long-standing quality improvement board in place with the organisation. I was very pleased to see the improvement in the nursing posts. There's a 27% increase in qualified nursing posts in the Trust, notwithstanding the fact though that this is the organisation that still has the highest agency use in place across our system. So whilst there are improvements made, there is some way to go, and we will continue to support the Trust with the work that they're undertaking. And then just finally, the report for Northumbria Care was published, the North Cumbria Integrated Care, and again, that recognised sustainability from a quality perspective and some ongoing improvement work, which will continue to support that particular organisation with. I'm pleased the North East Ambulance Service has had their first independently chaired oversight group following the publication of the report authored by Dame Marianne Griffiths. The purpose of that group is to absolutely ensure that the recommendations are fully implemented, and we will receive an update on that, Chair, in the spring, and the ICB Quality Committee is maintaining oversight of how that work is progressing. I won't go into detail on this, but my report does cover the priority areas of focus for winter. I'm also pleased to say that working closely with our local authorities, and my thanks to our ICB colleagues working in our place teams, all of our Better Care Fund plans have been signed off and agreed locally by Health and Wellbeing Boards and also nationally by NHS England. I'm delighted, Chair, to include in my report an update on women's health. So you will know that the first ever women's health strategy was published by government, and the £25 million that was allocated nationally for this was distributed across ICBs. You'll know from my previous comments on this, I was disappointed that that was wasn't allocated on an equitable basis in terms of the size of the ICBs, but notwithstanding that, we did receive £550,000. And later today, as an ICB, we will announce the first 3 projects that we are supporting for the creation of women's health hubs across the North East and North Cumbria, and they will be in Sunderland, Gateshead and North Cumbria, and we look forward to getting the learning from those women's health hubs in order to spread that. We had an incredibly well attended women's health conference hosted in Sunderland. We had the Women's Health Ambassador for England attend, Dame Leslie Regan, and Dame Leslie Regan has committed to attend one of our integrated care boards next year, where we'll be reporting on women's health. We know that so many of women's health services that we provide now could be better provided if they were provided in a more joined up and coordinated way, and not all of that requires funding. So I'm looking forward to getting the learning out of the first 3 hubs to see what we can do to better join up women's health and indeed improve the health outcomes for women across our system. And then, Chair, it has been an incredibly busy period. There's a few other things I just want to cover. You may have seen last week, Professor Chris Ham published a report on learning systems. We were one of several integrated care systems across England that featured quite heavily in that report for our work on Boost, which is included in my paper today. Boost is the North East and North Cumbria Learning and Improvement System. It builds on a very strong history here in the North East and North Cumbria of the North East Transformation System, and also the Cumbria Learning and Improvement Community, CLIC. We launched Boost this month. We already have 6,500 members of our learning and improvement community. Anybody can sign up to join Boost. A member of the public, a member of staff in health care services, voluntary and community sector services, independent sector services, in education and academia. And indeed, we've drawn members from across the world. The learning improvement community is a really rich resource of lived experience, professional experience, and we'll be wanting to nurture and grow this community. I'd really recommend all members of the board go online, have a look at the Boost site and see the type of work that's already been generated through this community. It will also be the sort of central learning portal for us as a health and care system. When I joined the system now nearly 2 years ago, one of the very strong messages across all of our partners in the system was there was much more we could do to learn together, to share what we're doing, to share the good practice. And when you look at that website, you'll see how teams across our system are visiting each other, they're undertaking peer reviews, and we're also running online sessions. I would highly commend you to look at the session on what's called the Liberated Method, which has been delivered by a director from Gateshead Council, Mark Smith, to get a really good insight in the type of innovative work that we're generating here in the North East, North Cumbria, and aiming to share not just locally but nationally and internationally. And as part of Boost, we held our first Children Young People's Mental Health Summit, and working again with nearly 300 people in that room, and that was led by many colleagues in this room. And I particularly want to thank Levi Buckley, Annie Laverty, Kath McAvoy-Carr for their support on this. But working across that learning and improvement community, we've identified our big 5 ideas to take forward, and we'll be progressing those and updating the board. And then just, Chair, just a couple of things just to finish off sharing. I do want to share a reflection on personal health budgets and listening to families. Probably about several months ago, I was contacted by a group of families in the north of our health and care system. And this group of families are all caring for people, members of their families who are in receipt of personal health budgets, sometimes with quite complex health and care needs. And personal health budgets, as you know, are something that are available to people to put in place their own care support. They can quite simply, for some people, be the difference from a more institutionalised care setting, very dependent on health and social care, to living a more independent life with their own carers' support in the most appropriate environment. I met a group of families that didn't feel that they had been listened to. I met a group of families that had raised concerns over many years about their experience of personal health budgets and the challenges that they were experiencing. And working with the team in the ICB, we have put in place a whole programme of work now around personal health budgets. That has started with a baseline assessment of how we do personal health budgets across the North East and North Cumbria. And it'd be fair to say, and again, this is based on a lot of legacy and historical arrangements, there are very different arrangements in place in each area we've gone to see, and we do have quite a lot of work to do. We will continue to work with this group of families. They've offered their time generously. They'll be offering their experience to help shape the work that we do. And David Purdue, our chief nurse, will head this up through our continuing healthcare. And for me, my thanks go to the families, because whilst we know that the ICB has inherited a lot of legacy systems and different ways of doing things, which is inevitable given we inherited 8 organisations across a very large area, I'm not sure if it hadn't been for these families, we would have spotted the types of issues and concerns they were experiencing. So I'm personally very grateful to them for sharing their experience with us. And Chair, you'll see in the paper a brief update on gender pay gap and the ethnicity pay gap. As an ICB, because we now employ more than 250 people, we will be required to report formally on the gender pay gap next year. But in doing the gender pay gap, I also think it's important we look at what's called the ethnicity pay gap. And we have now undertaken this piece of work, and there is quite a bit of work to do in order to determine what actions we need to address, particularly around reducing the pay gap, the gender pay gap and the ethnicity pay gap, and we'll bring the report back to board in the spring next year that sets out our plan to do that.
Thank you, Sam. It's a very comprehensive report. Are there any points anyone wants to raise, questions? Yes, please, David.
Sam, you mentioned the women's health budget. I think you said 25 million nationally. And if my maths are right, we should have received on fair shares about 1.25 million of that. And I wonder whether you said you were disappointed on the allocation. I'm not surprised. Do you actually know, and you may not be able to answer this, what the actual basis of allocation was? And are there any lessons to be learned for us in that?
I do, because alongside 2 other large ICBs, I did write to the Minister, the Department of Health and Social Care, about this, to raise this issue. The Minister, I think, took a decision that the initial tranche of funding was to promote the establishment of hubs to set up and learn from, and therefore the 545,000, I believe it is, was predominantly around set-up costs. I personally think that we needed to raise that formally, because if we look at the size of ICBs, they vary from providing support to a population of anywhere between 300,000 to over 3 million like ours. And therefore, even if you're looking at infrastructure costs, particularly in the face of running cost reductions, I do believe we need to look at fair shares. For me, the learning is around allocation across national schemes. And if decisions continue to be made where funding is not allocated on a fair shares equitable basis based on the size of the population, the North East North Cumbria will continue to lose out, and that won't be acceptable. And I think we need to be very vigilant about this, particularly when funding streams are allocated nationally.
Thanks, Sam. I'm very pleased you actually raised this with the Minister. Thank you very much.
Thank you. Kath McAvoy-Carr.
Thanks, Sam. Just a couple of points. One is around personal budgets, and it's an area that we are particularly interested in from a local authority perspective. So I feel like I'm a little bit of a broken record. So I'm hopeful that there'll be some partner agency involvement in that work that it is undergoing.
Yeah, Kath, there is absolutely, and we have got representation from local authorities as well. If you want to be included, you're always
That would
very
be
welcome.
lovely. Thank you. Thank you. I don't know how I've ended up with an additional task. And then the other issue is just to reiterate my plea around the reorganisation to make sure that the statutory organisations and the statutory partnerships that we have are appropriately factored into that issue. So thank you.
Thank you. Eileen Kaner.
Yeah, it's back on the women's health issue. I was really pleased to be part of the process of looking through some of the applications. I share your view that the allocation was not as much as we required, and I hope for more in the future. But my point is that often women's health is synonymous with women's reproductive health. And what I was quite interested to see applications that went beyond just the provision of reproductive services to think about different kinds of women and different kinds of health and well-being needs, including mental health. So I'd really welcome the learning from the initial setup, but really looking at the integrated health hubs to address issues beyond access to reproduction and reproductive health care. And I think the other thing really is also to think about girls, women to be, because I think their health needs and their mental health needs are often overlooked, and they are, you know, at a very, very formative stage about starting to develop their reproductive preferences and choices. So I didn't see an awful lot on girls, so I was hoping for more, and I really wanted to see at least later phases of initial plans to go beyond just the provision and access to reproductive contraception and other forms of reproductive control.
Thank you, Eileen, and absolutely noted. And the women's health strategy is throughout the whole of the life course, so it is women and girls, and much more than just those reproductive years where, you know, if Leslie Regan was here, she'd be saying that's historically kind of what the way we've looked at women's healthcare and the way services have been designed around women's healthcare, but it is absolutely through the life course. And I would agree, I think this is just a starting point and we can really grow this. And I should have also said that Claire Riley is our executive lead on women's health and may want to add to this.
Yeah, just to add, thanks for that, Eileen. We are actually developing an implementation plan that will come back to the board in the new year, which will include exactly as you suggest, Eileen. And realistically, if you look at the women's health strategy that was published by government, they talk about the cost-benefit analysis linked to every pound saves £5 overall in health services. So what we need to do is really look at the provision of services, how they link together, but also recognise there is also a cost-benefit analysis of getting this right and doing this well.
Okay, well, sorry, Sam, you want to comment again? Yes.
Yes, sorry, Chair. Just two other things I omitted. I also want to, it's being announced today, the appointment of Professor Dean Fathers as the new chair of the Health Innovation Network, formerly the Academic Health Science Network, and I want to welcome Dean to the region. And I also should have mentioned that yesterday I was in Sunderland with Ken, the Chief Executive of Sunderland South Tyneside, who's here today, marking the start of the construction of the Sunderland Eye Hospital. This is going to be an absolutely world-class facility located in Sunderland and certainly serving the region, and it was a real pleasure to be there. And I do want to really acknowledge not just the hard work of Ken and his leadership and his team, but also to thank our partners at Sunderland City Council for their support that have enabled us to, from an NHS perspective, build such a brilliant facility here for our population, and look forward to its opening in a couple of years, Ken.
That's a very welcome piece of news, because when I was here before as regional director, we set up the first fast-track cataract centre in the country in Sunderland. So Sunderland's very much been the lead on eye surgery over the years, and it's wonderful to see this further development coming in. Can I ask Sam, and you might want to ask Neil O'Brien, our Executive Medical Director, to deal with some of this. Winter, we're all aware, I think, of the extensive preparations that have gone on, but I wonder if there's a feel yet for the probably what will trigger whether winter is easy to handle or difficult to handle, the pattern of viruses that are emerging, COVID, flu, respiratory syncytial virus, and in some parts of the country, outbreaks of measles affecting children. So I just wondered if there's any emerging evidence really of how the viruses are going to behave this winter.
Yeah, thanks, Chair. So what we do know is that COVID numbers have had an early peak, and they've certainly been rising probably over the last probably 4 weeks. But if that pattern continues as it has in previous years, we'll likely get another peak, probably about another 4 to 6 weeks down the line. There was a lot of concern around the effect on people's health of the current circulating COVID virus, whether or not that would have severe impacts on people's health, but that doesn't appear to be the case. Admissions to hospital are increasing at a level that you would expect, but not accelerating. Flu, there's no reports of large numbers of circulating flu virus at this time, but obviously that's under that's under constant review. And RSV, there has been some increased numbers of RSV circulating in the community, but again, not anything out of the ordinary that we would expect. So at the minute, it's very careful observation, and it'll continue to be monitored through the winter. We do know that there is quite a lot of pressure from general respiratory illness, which is coming through our emergency departments and our general practices in order to try and support the entire community with those increasing numbers. We are looking to set up a number of acute respiratory illness hubs in all of our places, and they should become operational within the next couple of weeks. And they'll continue throughout the whole winter just to try and support the system in dealing with those that expected increased number.
Okay, thank you very much. And thank you, Sam, for your report. And we'll press on now to the next item, which is the Board Assurance Framework. And Claire Riley, our Executive Director of Corporate Governance, Communications and Involvement, is going to deal with that. And on this item, we're required to satisfy ourselves that the report accurately reflects the principal risks to achieving our objectives as well as current mitigations. And then after listening to Claire and raising any points, to consider whether we wish to approve the report.
Thank you, Chair. Hopefully board members will be familiar with this report. This is a living document. It evolves every time we bring it, dependent on the risks that come through. This is, as the Chairman has already said, to provide assurance to the board on the management of our key risks. You will see that we have aligned those key risks to our Better Health and Wellbeing for All key goals. And hopefully you can see the golden thread from our strategy through to how we are managing our risks, and you can also see the mitigations that are put in place as a result too. You will also see the detailed corporate risk register behind the Board Assurance Framework, and it provides you with a wealth of information. I'm happy to answer any questions, Chair, but hopefully the board are minded to approve this document.
Okay, any questions or comments? Yes, Mike Smith.
Thanks, Claire. This iteration of the document is excellent, and the golden thread is really clear, and the alignment to the strategy is really useful. I guess what's concerning is that when we look at the scores and the current trajectory where we're off target in most areas, is there any optimism that at some point we're likely to regain target? I appreciate there's an awful lot of mitigations and work going on to try and overcome these things, but some of the very honest examples of why we're off target in various different areas don't seem easily overcome in the short term, at least, or even sometimes in the medium or longer term. I just wondered what your thoughts were on that.
I suppose it depends on the risk that you're referring to, Mike, and obviously this links to the corporate risk register that my colleagues obviously input into. And if the risk is linked to clinical, obviously Neil will have that detail, or David. If it links to broader performance, Jacqueline will have that information. I think overall, this is a fair reflection of where we think we are as an organisation and as a system linked to our key strategy goals. and they are informed by an assessment based on where we are with regards to our activity. So unless you can specify necessarily what area you want to go into.
So no, it wasn't to bring up any specific indicator. It's saying it was just that taken in totality, lots of the indicators are in the red or in the orange, and that's, I guess, a concern as to whether we're likely to meet the goals that we've set ourselves as an organisation.
Yeah, I think again this reflects the reporting that our execs do. I can't necessarily brief you on where we are on with regards to hitting targets, but you know, from a finance point of view, David will be able to give you a position, and that reflects in the paper that's already on the agenda, Mike.
And comment.
Yeah, thank you, Chair. It was just to say that we have just agreed our risk appetite. As you know, we did some work with the board, and on the back of that, we will be doing further work with the risk owners, particularly around target risk, to make sure that they do reflect that appetite, but also that the proper mitigating actions are in place. Because I think I do take your point that some of them aren't quite to the target just yet. But I think once we've done that piece of work over the coming months, hopefully you'll see the difference.
Thank you. Are there any other comments? David, you looked as if you were about to put your flag up, but go ahead.
Yeah, thank you.
David Chandler.
Thank you, Sir Liam. So I will touch on the finance update, but there is some good news on some of the financial risks that we're actively managing at this moment in time. So if you're okay to hold your horses till then, I'll happily update there. Is that okay?
Okay, so people have... yes, Ken Bremner.
Perhaps on the comment that Mike made, it might be helpful, he made one or two of those, Claire, if we got a target in tracking to 2030, which is whatever, 5, 6, 7 years away now. So I suppose the point is we don't want to leave it until 2029 and suddenly go, oh my God, we're off track. We might want something in the interim that just suggests it's getting better or it's getting worse. So maybe just expand that a little bit perhaps, and that might help board members get a feel about whether that 10% reduction, for example, on the first one, actually is going the wrong way. We just, all it's saying is we're not going to hit the target.
Yeah, that makes sense, Ken. We'll look at that. And also, obviously, I'm conscious that we've got the integrated delivery report as well that actually provides that information too with regards to whether or not performance has improved or declined as well.
Should be easy to do then.
Yeah.
Right, and then Jacqueline Myers, Executive Director of Strategy and Operations.
Thank you, Chair. Just to add that at the next board meeting, we're bringing an implementation plan around our joint forward plan. So that's the 5-year horizon rather than the 1-year horizon that we focus on the integrated delivery report. And I think that will help inform the refresh of the risk assessments. Thank you.
Okay, thank you very much. We move on from that item on to the reports from committees. As you all know, a lot of the work, preliminary work on the matters that come to the board is done by the statutory committees that we've established as part of our governance structure. So first of all, the Executive Committee, which is chaired by our Chief Executive, Sam Allen.
Thank you, Chair. And the highlight report covers 2 meetings, 12th of September and the 10th of October. And just want to pick out sort of 3 key points from these. The first one, we received a comprehensive update around delivery of our interim equality, diversity and inclusion implementation plan. So there are a number of statutory responsibilities that we have in the Integrated Care Board with regard to this, and also working across the system to help shape and influence diversity and inclusion, particularly in our workforce, in our leadership representation. And Hamid Matraghi, our Director of Equity and Inclusion, has led this particular piece of work, and it was good to note that we have made quite significant progress in all areas of the plan, Chair. The second one was around service development proposals. So the allocation of what's called system development funding for 23 and 24 was presented in October, and this funding is always allocated to pursue specific areas of development, and we particularly felt it was important that the resources focusing around primary care were fully utilised this year, and we did receive a paper from the Primary Care Strategy Subcommittee which set out how the remaining funds in that budget would be to be utilised, and these were approved with the request of detailed delivery plans to put those in place. And then just finally, Chair, we've adopted what's called the Integrated Impact Assessment and the plan to use this tool across the organisation, and this will help us have a tool and approach, particularly when we're considering services or policy changes in relation to equality and health equalities, and that we've got a sort of clear process as an integrated care board for that. So the committee approved the use of that tool for any of those changes proposed. It would probably be fair to say the key risk, and this links to the conversation actually we've just had on the board assurance framework, has been particularly around the finances, particularly the work we're undertaking around what we call the medium-term financial plan. So we're looking at the next 3 to 5 years for financial planning and the risks that we know exist across the system with underlying deficits. I've already spoken this morning about our plan this year, which is a deficit plan, which we will make a marginal improvement on, and that 35 million deficit we will continue from a revenue perspective into next year. So we know that the resources will continue to be tight for us, and we are just coming to the final stages of developing our medium-term financial plan. I hope to update the board on that in the new year.
Thank you. Does anyone have any points they'd like to raise on that committee's report? Thank you very much. Then we pass on to the Quality and Safety Committee and our non-executive directors who chaired those meetings, Eileen Kaner and Hannah Bowes.
Thank you, Sir Liam. So I'll begin by just pointing out that the last meeting we presented the minutes from March. Our committee took a skip in time in order to come into synchronicity with the Finance, Performance and Investment Committee, because we share an integrated performance and quality report. So here we have a bundle of minutes that relate to the meetings in July and in September. In overview, I think it's probably fair to say this is a very busy committee. I think there's 7 plus committees that sit underneath it. We were in place before some of the place-based arrangements were in place, so I think it's taken a little while to make sure that all the place-based arrangements are in situ and reporting into this committee, which they are now. We have area nursing leads who are increasingly standardising how they look in their areas to try to bring their reports to this committee so we can see the wood and not the trees, just to look for some of the kind of issues in common and some of the learning that we can understand from some of the kind of major issues that come up. I think a real development around September is we had our first patient experience open the meeting. I think because I've mentioned these are quite sort of information-heavy meetings, sometimes you can feel further and further away from the patients who are at the heart of our health and care services. And so actually having the meeting beginning with a grounding in lived experience, I think has been really important to the committee. Our first patient experience reported their own lived experience around mental health need and the requirements for trauma-informed care. And then we had a patient experience contribution on neuro-rehabilitation at the last meeting. I'm going to hand to my vice, Dr. Hannah Bowes, because she chaired the last committee in November. So Hannah.
Yeah, thank you very much. We don't have the minutes available as yet. They're still being reviewed, which is why they've not been included, so they'll be brought to the next board meeting. But Neil has very helpfully pulled together a slide, which you can all see now, which just gives you a flavour of what we discussed a couple of weeks ago. I will pick up on a couple of things. So the first thing is obviously, as with all the quality and safety committees now, we're really embedding the patient story, and so we start our meeting off with that, and it sort of grounds the sort of discussion in the fact that we're talking about real people. I think sometimes when you're getting stuck into reports and looking at numbers, it's all too easy to forget that, you know, there are individuals behind this, and so that really helps us to kind of provide that framing, I think. And the topic this time was on neuro rehabilitation, in particular an individual who'd struggled with transition of care outside of hospital and into the community, and not having the sort of right support in place really, and having to actually go private to get that support in the end, which is obviously not what the NHS is there for and what it's striving to do. So that was a really powerful example. Some of the things that we discussed have already been raised today in the meeting, so I won't go through all of them. One of the main things that we looked at, a cross-cutting theme actually, was how best to present the information at Quality and Safety Committee, because there is so much of it, and actually how best to deliver that to us so that we're able to interpret it and use that. So we've been using, most of the reports came within a sort of an involvement and improvement theme, which actually has been really helpful in being able to digest that information, and it was recommended that that should be across all of the reports that we receive where applicable, to make that easier for us. The area quality report, I think that in itself had more than 100 pages, so that gives you an idea of the volume of information that we receive. Maternity update has already been touched on in this meeting. The IT related incidents was a big issue, so most of you are already aware of this, but it's affected a relatively small number of patients, but nevertheless the numbers sound, pretty shocking when you see how many thousands that equates to, although overall the proportion is relatively small. So my understanding as a non-IT techie person is that this is mainly to do with the implementation or transition to a system, and that system not being tested at all points to ensure that the sort of feedback was correctly in place so that any potential issues could be identified. But I can already see that our techie exec will step in and probably give a bit more information about that. And we escalated that up to this board, because clearly that is not something that just affects quality and safety, but actually cuts right across to be more of a major incident. So we escalated that beyond our committee. And then most of the other reports that we received were just for receipt and update, with no kind of major risks or issues to identify at this point, but you will receive the full minutes at the next board. Thank you.
Graham, are you going to supplement the comments about
yes,
IT-related incidents?
Yes, thank you, Chairman. Thank you, Anna. Just to comment on the IT-related incidents, so clearly anything that has a technology, a process or a person input has a potential for various aspects of failure. We have had a number of incidents of late, principally leading to correspondence transmission electronically from secondary care services to GP practices. I think the first of which was mentioned at the public board several weeks ago. Since then, we've had a small number of similar incidents, but not exactly the same. And what that allowed us to do was to create a bit of a framework now. So we're pulling together a system response, clearly to understand what went wrong, but the real important feature is to learn from those experiences and share across our system. I think when the recent Newcastle incident occurred, we did send out a note to all of our provider organisations to do a review of their correspondence systems. We will be reminding colleagues to do the same. We were expecting some national mandates to do that, but that hasn't happened as far as I'm aware. But we want to make sure that we learn, through the processes that Sam, our Chief Executive, mentioned previously. We are a learning health and care system, and IT has a multifactorial risk, as I said, people, process and technology. So it is part of our learning culture, Salim. Thank you.
Thank you. I'd like to just add a comment of my own on that, based on my long-standing interest in patient safety. But if you look at safety in other fields, between the 60s and 70s, it was all about hardware in the causation, or that was the paradigm. Then, as a result of in-depth analysis of some major air crashes, Chernobyl and the ferry disasters, it became human factors. But software has not really come under the microscope, and most pointedly came under the microscope with those two crashes of Boeing's, where basically it seems that the software was adjusted. And so I think if we're looking at healthcare and some of the parallels with other industries, we need to be very, very interested in the element to which software poses risks, and that it isn't a minor thing to adjust software or revamp it. But Graham.
Yes, thank you, Salim. And software is a key area of vulnerability, not least that it can go wrong most likely after there's been a change of some description. So within the health and care system, there are now standards that we need our suppliers to adhere to, and a continuous process of review and support linked to those software changes. So it is very much in the current thinking, software is an area of weakness.
Okay, particularly in prescribing as well, presumably.
All aspects, and when I touch on my presentation, I will allude to some of that clinical safety. Thank you.
Are there, David?
Thank you, Salim. I think the learning that we've had from these is that these have not been the system or the software. This has been user error in the main. And we have done independent harm reviews of all of the patients who've been early identified. And that's with, because it's primary care, we've had GP colleagues, independent reviews just to ensure that actually harm reviews have been done effectively.
Okay, thank you. Any other comments anyone wants to make on that very important business going through that committee at the moment, especially with some of the things that we've discussed earlier? Eileen.
Just a postscript, really. I think there's something really important about the interplay of the committee sub-board, and just wanted to say that, you know, because I attend the Finance, Performance and Investment Committee, 2 items there around infections and neonatal outcomes were raised. I was able to say that they were already on the quality and safety agenda. We get the same integrated report. I think it actually just shows the value of being in time and seeing the same information at the same time. But as the concerns were raised in one place, we were able to say they'd been attended to in the previous meeting in quality and safety. So I think that just gives assurance about how the committees are now functioning together to inform board.
Thank you, Chair. It's a bit of a theme, and I wonder if we've got some more work to do on this collectively through the Board Assurance Framework, and then notably in the papers of the Quality Committee. There are various references to shortages of capacity for things like leader reviews and other areas. And I just wonder whether or not we need to pull those together and just absolutely demonstrate that we're assured that we are taking the kind of relevant actions to address those capacity shortfalls, rather than us all collectively just sort of noting those risks and concerns.
Mike Smith.
Just a brief point. One of the items referenced in the paper was the establishment of a clinical effectiveness subcommittee. I think that showed a sign of maturity of the group. Having previously sat on the quality committee, the volume of work that's covered is absolutely enormous. So the recognition that there needs to be a subcommittee structure so that the items can be given the attention and the time that they deserve is really positive.
Thank you. I think everybody who... Yes, Eileen, I want to come in again.
Yeah, it was just the issue of capacity that Sam raised. Certainly when we were having the extraordinary board thinking about the financial allocation, there was clearly when times are financially straightened, there's always a concern that that could affect the safety and the quality of the care that we are needing to deliver. And so I think it is a really good time now to actually just, within our current financial situation, is just to be confident that we've got the capacity to do some really important work around safeguarding and the like.
Okay, thank you very much. If we could now turn to the third committee report. It's the Finance, Performance and Investment Committee, and the chair is John Rush, our non-executive director.
Thank you, Salim. And obviously you've got in the report the minutes from the 7th of September and the 5th of October, and whilst some of those points that are up there are from November, some of them from the other meetings as well. So I just wanted to talk about, first of all, the independent sector. We asked for a presentation on the independent sector, primarily because in terms of the growth of the independent sector, because from 2019 baselines in terms of budgets, there's been a 73% increase of independent sector costs, as it were. And this year, whilst we are looking at a budget initially planned for 71.5 million, it's forecast to be about 103 million. So that was one of the reasons why I wanted to look at it. And the things we got from the presentation is that very good turnaround times and very good, should we say, outcomes for patients in terms of what was being done. But also as well, trying to balance that up with some of the independent sector take on board things that are more routine and less complex. And obviously, to a certain extent, there's an impact on some NHS services around that, because some trusts obviously operate trying to do routine with complex, and there's a big demand on that to do both. So it's a question of what was the impact potentially of all of that on our NHS services. And one of the things we got in terms of assurance was that during the reorganisation for ourselves as an ICB under 2.0, that the joining up of the contractual arrangements with some of the quality arrangements for independent sector and other parts of our, checks that we do, that will maybe start to have a bit more of a look at that. I think from our perspective, we found that quite reassuring that there was going to be some join up on that. So that was an important presentation. Then we also had a look at prescribing, again, another presentation. And again, to a certain extent, there's due to, should we say, a 13% increase in spend for us as an ICB, and that worked out around about £35 million extra for us in terms of our budget. And what we were given is that it's mainly uncontrollable price increases to do with prescribing. But from the perspective of, okay, well, there's some things that you can't control. What can we control in terms of our governance arrangements? We, again, were assured that in terms of governance, there's an ICB medicines group, and there's also the Northern Treatment Aid Advisory Group, and of course that reports into the ICB exec group. So again, we knew that there were mechanisms there that were operating to try and work out exactly what was going on with the prescribing side of things. Finance, I'm not going to go too much into, other than that we obviously get the finance report every meeting, every month. We understand the risks that are involved. We get what mitigations are being put in place. And I know that David will spend some time later on talking us through in much more detail about where we are with our financial position. But again, for us as an assurance perspective, we are fully across that and get all that information on a monthly basis. The same with performance. And I'm not picking up major performance issues in this sort of short update today. But one of the things we just talked about was obviously say this inequality and impact of some initiatives. So it came out really in a discussion about patient choice. And obviously in terms of patient choice, which is great, you can make a decision, can we move elsewhere to get this? Are there some places that will be able to do this? Not only NHS organisations, but independent sector. But then again, we didn't know or understand the impact that could have on people who may be less able to travel great distances. And it's still early days in relation to where we are with patient choice and how many people have chosen to change their appointment place. But obviously one of the things is to remind people what we can offer as organisations and what we can't offer in terms of supporting people with transport. But there was just that was a discussion that we had. And then finally, just the fact that we are now taking on board, we had a sort of update about oversight arrangements, and that we're now taking the responsibility for looking at trusts, not only those that are in, say, soft intervention, but those ones now in like a much more involved intervention. That in itself is a big responsibility. And I know you talked about resources before. What impact does that have on us being able to manage that whole process as we go through a challenging time for the NHS and organisations over the next 12, 18, 24 months. So there was just an oversight really of where we got to in terms of the things that we thought were important to raise today, Salim. Yeah.
Thank you, John. Are there any comments anyone would like to make or questions? No. Well, thank you again for all the committee chairs, because I know it's a great deal of hard work that you do with your colleagues on the committee, and it's very, very important that everything that comes to us has been thoroughly dealt with, and that we have good oversight of it. We move on now to item 10.1, and just let me start by deciphering the acronym, which some people will be familiar with, but it's learning from the lives and deaths of people with learning disabilities and autistic people. And this is the annual report in that area, and our Executive Chief Nurse, David Perdue, is going to introduce it.
Thank you, Salim. The report is our first inaugural leader report for the ICB, and fulfills all its requirements as directed by NHS England. So during 22-23, we had 163 reviews from the deaths of people with a learning disability. There were 28 initial reviews and 35 focus reviews. The top 3 causes of death were 38 people died of pneumonia, 17 of cardiovascular disease, and then 17 of aspiration pneumonia, which obviously is a rare cause of death for people without a learning disability. For the first time this year, we've done 4 reviews of people with autism. They're all men, and they're all focused reviews as the policy requires, and a very different cohort of causes of death in terms of 2 with drug misuse, 1 with cardiovascular disease, and 1 with suicide. Just to focus on some of the work that we're doing and what's supported some of the lengthening of lives, even though there's still the 28 years of difference between somebody without a learning disability and autism compared to those without, is in terms of the improvements in end-of-life planning, and then an increase in the uptake of annual health checks, and flu and COVID immunisation has played a big difference. Just in terms of ongoing concern, it is around the competency and capability within the team, because all deaths require a review, but there's no new learning been uncovered. But we are looking at, as in part of 2.0, how we centralise the team, so we have all the expertise in one place, because there's obviously multiple teams at the moment with differentials in kind of how they fulfil their roles. So we have looked at that really closely. I'd just like to draw people's attention really in terms of the improvement work that the Learning Disability Network's led. So they're working with Macmillan on the National Easy Read Holistic Needs Assessment, the rollout of mandatory learning disability and autism awareness training to all the health and social care workforce. So the gold standard for that is Oliver McCowan training, which is 3 levels of that. The first level is fairly straightforward, it's 45 minutes online. The second level of training is much more complex. We have to have teams of people who have got lived experience. Now we've got 3 teams who are one of the pilots for the training. A number of our organisations already comply with the Diamond Standards, which is very similar to Oliver McGowan, but we are working with our providers. And as an ICB, we're only required to train people in health, but we don't think that's the right way to do. So we are supporting social care as well as health care. So we are piloting the use of the Bubble app for people with learning disability and autistic people to track their health and well-being, and then working with Skills for People to implement the Live Well programme, which promotes good health and well-being for people with learning disability and autistic people using social media. So happy to take any questions on the report.
Thank you, David. Other points and questions people want to raise? Rajesh.
Thanks, David. I think the report's really welcome, and I suppose in the actions which we've taken around annual health checks, immunisations, those are the right actions which will give us some impact over time. My question was about what is lacking in the report, given the deaths with regards to, heart issues, cancer, whatever, is that there's no reference made to the care which people with learning disabilities receive in acute hospitals. Was there any learning in that context, which we hear from other areas, whether it's CQC reports and so on, which you could triangulate with this report?
That's a really good point, Rajesh, and obviously we do look at that from a different lens. Obviously this is the work of the network, which is much more strategic. In terms of our oversight of care of people with learning disability or autistic people in hospital, we do that through different mechanisms, but you're quite right, we should triangulate it with this.
Sarah Malik.
Thank you. Thank you for that report, David. It was very insightful and a brilliant read. I particularly like the element at the end of the report, which is very easy read for those people that we are reaching out to and want to engage with. My observations and questions really were around, identifying any pieces of work that we could do with vulnerable groups or ethnic minority. And I know there will be something happening in the background, but I think it would be useful to have a greater insight into that. And I also was curious about any research collaboratives that we were doing with voluntary sector as well as care providers as well. My final point is just around communication. As we know with vulnerable groups, there is a way to communicate, and just to raise the importance of getting health checks done. You know, what are we doing to engage with our vulnerable groups and their carers to ensure that there is an understanding of the seriousness and the importance of having these checks done?
Thanks, Ira. So in terms of the first one, in terms of ethnic, minoritized ethnic communities, that's one of our key pieces of work this year, and leading into the tackling of health inequalities and early identification and prevention. So that's a work stream through the network. So very happy to have a conversation with you and feedback on that. In terms of communication, we had a great event with people with lived experience, actually sharing how they needed to be communicated with and what was the best way for us to do that. So we're going to work with Claire's team to look at some of the ways that we do that and how we simplify some of that. So when I walk around our kind of acute providers, actually it's a minefield trying to navigate a number of them. Yet there's some really easy signage that we can do and do things very differently. So we're just working with the trust on that.
Okay, thank you. I think we've talked informally about having a further strategic discussion on this at a future meeting. Sam, would you like to say something about that?
Yes, thank you, Chair. I was minded that one of the very first items we had as an integrated care board was listening to a group of people with lived experience with a learning disability and the impact of shortened lives through the worse outcomes they experience. And I think this is an excellent piece of work, and I think our commitment that day to that group of people was that this was going to be a really significant priority for us as an integrated care board, and therefore I think it's good to receive the annual report today. It's really good to know how the learning's been translated into actions and they're captured in the report. I think we need to make sure we have really laser focus attention on the delivery of this, and I think we should have a longer session looking really at the outcomes and really challenging ourselves on, are we shifting the dial here? Are we increasing life expectancy? Are we making a difference to the lives of people with a learning disability and their family and friend carers? So we'll do that next year, Liam.
Thank you. I mean, I think it is one of the advantages of an integrated care board like ours and an integrated care system. We have 3 million people, and as I've said on a couple of occasions recently, that's bigger than about 30 or so countries in the world. So we're as big as some small countries, and a tendency for, particularly with services in an area like this, which need true integration, but also coordination and a consistency of best practice across all of the individual smaller areas where it happens. It's an opportunity, I think, to make a major step forward and try and do something really special. So we will come back, having reminded us, Sam, that this was one of our early topics for discussion when we were formed as a board, and the annual report's been a helpful marker on the journey, and we'll come back to a longer strategic discussion in the next few months. So thank you. Yes, Hannah Bowes, Non-Executive Director.
Thank you. Just wanted to say that this broadly, this was discussed at the Quality and Safety Committee in relation to secure services and our sort of admissions and discharge in that. And one of the things that I thought was interesting, again, the minutes will be available later on, was that sometimes the statistics can look bad in the sense that we're not discharging people at a rate that perhaps we would like to for whatever target we might have. But actually one of the things that was discussed was that for some people with learning disabilities or autism, actually the reason they're not being discharged is actually because they don't want to be, and that actually sort of going at the pace of the individual is really important, you know, and that actually what we think might work in the general population isn't always actually suitable. So I just wanted to say that I think sometimes the stats that we look at can look bad, but actually when you think about the individuals and the sort of variability of people's needs, actually you realise that for some people they need a sort of different response or a longer time than perhaps we've traditionally allowed for.
Thank you very much. Tom Hall, partner member.
Yeah, thank you. And just building on the points around a strategic discussion, looking at the lessons learned. I think I might have mentioned this in one of our board development sessions, but we have a number of learning processes in place, things like child death overview panel processes and domestic homicide reviews, drug and alcohol death processes. I just wonder whether there's something about looking at common themes for where we've got modifiable factors or things that we could look at, not to dilute the issue of learning disabilities and autism, perhaps thinking about where there might be some common ground across those issues.
Thank you. Lisa Taylor.
Thank you. It was just to raise that if you were looking at a deeper dive into the learning disabilities and autism issues, we've got a learning disabilities and autism subgroup as part of our partnership programme, and would really like to link in and support you with any of the work that we can. And it includes membership from organisations you're already working with, such as Skills for People. And one last point around, just to echo that the report was really well presented and easy to read, and it brought to mind that we make all of our papers available online for everybody. Should there be something we're thinking about as a board, as doing an easily accessible version of all of the papers that we're presenting for people?
Thank you. Levi Buckley.
Thank you. Just pick up response to Hannah's point, because we, as you know, we're doing an awful lot of work around the Transforming Care programme to support people's discharge from hospital. I think Hannah's absolutely right. There are a number of individuals who will feel anxious and challenged about moving out from a hospital setting to a community setting. I think perhaps the other side of the coin is our responsibility to have stimulated the market for the right kind of supported living, to continue our work on growing the workforce so that's the right kind of support to keep people safe. And I suspect, Hannah, that part of people's reticence maybe is our responsibility to give them the confidence about those wraparound offers of support to live independently. So I think we've got some way to go. And just reflecting on the action log, Salim, again, I think we'll look in the new year of bringing a bit more detail on our Assuring Transformation programme back to the board to kind of cover some of that ground.
Well, thank you very much indeed for the report and the discussion, and with a promise to do a lot more in this area. So thank you. And if we could now turn to item 10.2, the Integrated Delivery Report, and that's going to be presented by our Executive Director of Strategy and Operations, Jacqueline Myers.
Thank you, Chair. So, as in previous board meetings, you've got the comprehensive integrated delivery report before you. And indeed, a number of the items covered have already been touched on in the Chief Exec's report and the committee subcommittee reports. So this month, in a slight change to approach, I've got some slides to share with the board just to draw out some real significant headlines, and then, as ever, I'm always happy to take questions on any of the items covered in the report. So these are the areas that I'm going to cover. In order to do headlines, obviously it's not a fully comprehensive look, and I think in future months we'll have a bit of a deep dive into other areas. But this morning I'm going to have a look at our performance in relation to some key metrics relating to urgent emergency care, elective care, cancer, and some mental health and learning disability waiting times information. So I'm going to start with the, I'm going to move on a little bit, urgent emergency care, and talk first of all about our category 2 response time. So as the board knows, this is one of the categories of ambulance response time standards. This is for not the most serious category 1 responses, but the next serious, so typically things like suspected heart attacks and strokes. And there is a national ask that we hit an average of 30 minutes in responding to these ambulance calls over the course of the year 23-24. Very important category for us because I think, as I mentioned before, it's the majority actually of our ambulance calls, about 60 to 70% in any given year. So as you can see from the graph there, after a very difficult period last winter, we have seen a sustained improvement in our waiting times. However, unfortunately, we're not yet getting to that 30-minute average across the year. In the first 6 months of the year, April to September, the average was 34 minutes. And the current position you can see there for October was 34 minutes and 54 seconds for the month of October. Just to give you a helpful bit of context, we benchmark this against the other 10 ambulance services in England, and during October for Category 2 we were the 5th out of 11 in terms of the timeliness of our response. We've recently done a bit of work with the ambulance service to review their approach to this, and we've agreed a comprehensive recovery plan that we're working with them through a formal oversight process. And I'm pleased to say that we've seen them sort of stabilise their position after a concerning dip in performance in August, which traditionally would be one of the easier months to hit the target because the hospitals that were over half the Category 2 ambulances end up going to are typically not quite as pressured in their A&E departments as they are later in the year. And so we're watching this very carefully, but at the moment we're seeing a sort of stable performance. We do have now a plan to improve this over coming months, and you can see there that we're aiming to get to 27 minutes and 5 seconds average over the month of March. The second bit of information on this slide is about ambulance average handover times, and this is the time it takes from an ambulance arriving at a hospital to the patient being accepted into the care of the hospital. So, I mean, something in an ideal world we wouldn't be concerned about at all, but as people will know, it's been a matter of difficulty for a number of years now. There is an ambition that we achieve an average of 15 minutes with no patients taking more than 30 minutes to hand over. And although no specific objective was set for systems during 23-24, we've focused on this very closely because we recognise the close interrelationship between delays in handing patients over at the hospital front door to the accident emergency department, and then how long it takes to deliver that response time above for Category 2, because clearly if our crews are waiting to hand over, they're not on the road collecting their next patient. So the current position in the northeast, in the northeast, I should say, because this is NIAS data, is 21 minutes and 50 seconds. The position in the Northwest Ambulance Service, I should note, is better than that, and they are the ambulance service that serves our Cumbrian hospitals. We have set a plan to improve this, getting to 19 minutes and 4 seconds by March, and indeed since these slides were written we've developed ambitions to go even further on that, and I think you will recall that the Chief Exec mentioned we've done some replanning, if you like, mid-year resubmission of plans in the health service since we last met as a board, and for the first time as part of that process individual hospital trusts were required to commit to a plan to improve their ambulance handover times, and we're in the process of developing bespoke improvement plans for each of our 11 accident emergency sites across the 8 trusts who deliver those services. And so we've made a commitment to work towards achieving a maximum of 15 minutes, and as part of that committing to an absolute backstock of 44 minutes. The board will recall last year we committed to 59 minutes as our backstop position, and we monitor that very closely. So I'll be giving the board a further update on that work at the next meeting. Just turning then to our accident and emergency 4-hour target, the top left graph there you can see our plan, which is the orange line, and then our actual, and so you can see that we were doing pretty well against our plan for the first couple of months of the year, but in August and September we've fallen below the plan we set for ourselves. The national objective here is to achieve 76% of patients being seen and either treated and discharged or admitted within 4 hours. The current position in October is that we delivered 75.4% against a plan of 78.6%. As part of that replanning round, we have reset our plan for the end of the year, March, we've reduced it slightly from an 81% plan to 79.9%, still in excess of the national ask. And in terms of benchmarking data, over the last few months, we've remained in the top 5 ICBs in terms of the performance against the 4-hour target. But of course, we like to treat those benchmarks cautiously because we're still a long way from where we would like to be. People may recall that a number of years ago, it was common to be delivering performance in the 90s, and indeed even in 1920, we delivered a performance in the high 80s across the organisations in this patch. So very keen to see that improve. Again, I just thought it was helpful to share a supporting metric here, one that's perhaps less visible but very important, and this is about patients who have a delay in getting into a bed once a decision's been made to admit them to hospital. And you can see here that we have, a significant number of patients waiting over 12 hours to access a bed. These are the data for the last 12 weeks. Again, pleased to say that this is a problem that's less of a problem here in North East and North Cumbria than it is in the rest of the country. However, it's still a matter of concern and something that we watch very carefully. As noted on the slides there, pre-COVID, it really was a relatively rare event. 113 of these waits happening across the whole year, whereas you see here we're having between 100 and 200 in our worst week there. So a real concerning metric and one that we hope to improve upon. In our plans this year, we were fortunate to get funding up front to put additional beds into our hospital system. Rather than waiting till winter to occur, we planned those from the beginning, and I'm pleased to say that we've delivered, in fact slightly over-delivered on the additional beds that we sought to put into the system, and we hope that will protect us from long delays from decision to admit to getting into a bed over the winter period. Just going to move into the position in terms of elective or planned care. And apprise the board of where we are in terms of the very longest waiting times that we have for patients across North East and North Cumbria. We measure this in weeks. I can translate it for you. I'm sure you realise that 78 weeks is a year and a half wait. So that's the wait from being referred by your GP to having your definitive treatment. The national objective was to eliminate these back in March. We got close to that within the ICB, and prior to any industrial action, we were only seeing waits over 78 weeks on our complex spinal pathway. However, unfortunately, through the extended period of industrial action across the summer and early autumn, we have seen a deterioration in this position, and you can see there that as of last week, we had 313 patients waiting over 78 weeks, which is obviously a terribly long time, and those patients are split between the Newcastle upon Tyne Hospital Trust and the South Tees Foundation Trust, our two big tertiary centres. We hope, if we see no more industrial action, to make very rapid progress on getting these patients treated over the coming weeks, and we have just agreed improvement plans with our organisations. Sadly, those plans don't see these numbers fully eliminated by the end of March. I have to say, I think we can go a bit further on this, and we were given a very rapid turnaround time to submit the recovery plan. At the moment, it sits at 170. That's made up of 167 patients, plus 3 risks, who are all patients waiting for corneal grafts. There's a national supply chain for access to the grafts themselves, so we'll just note those because we're not in control of whether or not we'll be able to treat those patients. It will depend on not whether the transplant graft is available. In relation to 65 weeks, a year and a quarter, if you like, the national objective was to get all of these patients over 65 weeks treated by the end of March, coming March 24, and we had a plan to all but eliminate those waits, just down to 14 complex spines. Unfortunately, again, we've seen a real deterioration in this position, again related to lots of reduced activity and cancelled operations as a result of the industrial action. So you can see there, at the moment we have just over 2,500 people across our geography waiting over 65 weeks. We've just landed a plan to reduce that to just over 1,100, 1,145 by the end of March, and again we're going to be working closely with our trusts to try and better that plan. Just to mention a couple of things that's going on in that regard, as well as obviously all of our organisations working hard to maximise the levels of activity they deliver. And it's worth mentioning that in relation to elective activity in value terms, we're on target to deliver 112% of the activity levels that we managed the year before COVID. So, more than 100% recovery. lost my thread there. Yes, so that's the activity levels. And the other two things I wanted to just briefly mention is that the Provider Collaborative has just recently approved its mutual aid framework. That's the arrangements whereby they offer patients alternatives to move to other sites that have slightly shorter waiting times. And we're also participating in the national programme of what we're calling patient-initiated choice. It's known as the PIDMAS system, and that's where all patients over 40 weeks are written to and asked whether they would be willing to travel to get treatment at an earlier juncture. And at the moment, about 4% of the patients we're contacting are expressing a willingness to move. So we hope those two initiatives will help reduce these very longest waits and help us better the plans that we've got here. Moving to cancer and the diagnostic targets, the top set of this slide looks at what we call the 62-day backlog. So the board will recall that the national standard is that anyone who's referred with an urgent suspected cancer is either treated or discharged because they have a benign diagnosis within 62 days. And what we're focusing on is clearing the backlog of patients who are already waiting over 62 days, whether they still be suspected or confirmed cancer. And you can see here, we had a bit of a peak across August and September where we went significantly off plan, but slightly better news, we're starting to return towards plan. And I'm pleased to say that all but one of our trusts has confirmed that they will deliver their plan for the end of March. The one trust that's tweaked their plan slightly, North Tees, has added just 17, so that's still quite a significant improvement from them going from 115 today down to 56 by March, and still well below the national target we were set for improvement. We were asked by the national team for a backlog, to achieve a backlog of no more than 861, and our revised plan is for 817, so I hope to deliver the orange line that you see there. In terms of diagnostics, I'm terribly sorry, this is quite small for the board, but looking at the wiggly lines there, what you're seeing is the percentage of patients who are waiting over 6 weeks from referral to delivery of a routine diagnostic test. There's a basket of 15 tests that we monitor here, things like CT scans, endoscopies and so on. The orange line is the percentage in England who are waiting over 6 weeks, and the blue line is our local North East and North Cumbria population. So you can see there that at the moment we're at 15%. That's a bit of an improvement, but not massive. As you can see, the line wiggles around quite a bit. We're doing quite well in terms of activity volumes, again here, well in excess of previous rates. And the national ambition is that we get to no more than 5% waiting, but by March 25, so we've still a year and 4 months to work on this. So some progress, but we'd really like to see this step up. I think we've reported previously to board, we have been fortunate in getting approval to build 4 diagnostic centres around the patch, which will increase capacity, and we've also got some additional investment going into a couple of endoscopy departments, so we would hope to see a step up in the spring in terms of level activities we're able to deliver here that will enable us to land a plan next year to achieve that 5%. And then just finally, Chair, I wanted to touch on something that we shared with the board for the first time last time, which is that bit of work that we're doing within North East North Cumbria is to look at the waiting times for children and young people looking to access mental health services in general and for diagnosis pathways for autism and other neurodevelopmental conditions. What we've done, which is slightly novel in that the 18-week targets and the 65 and 78-week targets are not routinely applied to mental health services by the NHS in England, is we've looked at these waiting times in the context not just of how many people are over 13 weeks, which is the national measure, but what the length of waits are. And there are some really concerning numbers here, as you can see. So for children and young people's waiting times overall, we have 2,800 patients waiting over 2 years, and on the neurodevelopmental stroke autism waiting time pathways, we have 902 patients waiting for children and young people waiting for a diagnosis. And this is an issue that we're very concerned about and very focused on as a board, because we know that very difficult time waiting to access these services. We had a presentation to the board last time about all of the work that's going on to transform services. I think we mentioned, amongst other things, that we're looking to do a re-procurement in the spring to extend access. We've done an extensive recruitment programme to try and identify more talking therapies to support in the general waiting times. And some of the work that we're doing in the autism and neurodevelopmental mental pathways is that we're applying some of the learning from the physical health sector in terms of how we manage waiting lists, how we look at redesigning pathways, and also mutual aid, because underneath these headline figures there are some quite significant differences in places where waiting times are worse in some places than others. So we're looking at whether we can deliver some mutual aid to reduce those very long waits, and we'll bring a further update to a future board in progress in that regard. So then just looking at the adult waiting times, a similar picture really. We've applied those same measures. We're now got a very clear picture for the first time, not just of the number of people waiting, but the extent of those waiting times. And this will enable us to, as I've mentioned, in relation to the children, really focus on where we can look to reduce these longest waits. And then finally, on this sheet, I've mentioned the out-of-area placement bed days. So these are patients who require an inpatient admission, and unfortunately we're unable to find a bed for them locally, and they end up being sent out of area. This is something that we're seeking to eliminate, and we have an improvement trajectory, which we've never achieved zero, but we have seen a real significant improvement on this over the last few months. So I think you'll recall that it peaked at over 800 during the summer. We're pleased to say that that's coming down nicely, and this is credit to a whole range of teams, but particularly our two mental health trusts, who've really overhauled all of their arrangements to manage their bed processes and their admission processes. And essentially one of the really significant developments is to be looking at people who are currently out of area alongside potential new admissions, and taking a view of their relative needs, and also making sure that we've got high visibility in all of our discharge planning processes of people who are placed out of area, and that we're seeking to repatriate them to a place more local to their home, alongside the sort of longer term discharge planning to get them back into the community. So that's the areas I wanted to draw attention to. I just wanted, if I may, Chair, just to comment on one other thing, which is relating to the oversight arrangements that our Chair of the Finance and Performance Committee referred to. So just to say that we've been asked as an ICB to pilot leading the oversight of all of our providers on behalf of the regional team, and whilst I absolutely recognise it's additional work, I think it is a recognition of the kind of quality and robustness of the oversight arrangements that we've been delivering with our providers over recent months. And so we'll obviously be taking a careful approach to that to ensure that we're able to deliver that across the whole system, but I think that's a helpful development. Thank you.
Thank you very much, Jacqueline. Comments and questions then, David Stout.
Yeah, just on your last point, Jacqueline, I mean, the ICB and yourself are to be congratulated for being given the honour and the trust of actually piloting this on behalf of the NHSE, so I think that's really good. My question really is around elective side, and under the financial agenda, my understanding is that NHS England allocated the additional resources that they've done very recently, and they've said the priority is to deliver financial balance and to deliver urgent and emergency care. Now that's a directive, if you like, across the whole of the NHS. Do you think that will impact upon us within the North East and North Cumbria, or do you think our constraints are not so much financial but operational, on the back of shortage of beds, consultants, industrial action, etc., etc.?
Yeah, okay. I think we're fortunate in North East and North Cumbria that at the point where we went into the replanning exercise, we were already exceeding our plan. We were asked to deliver just short of 109% of 1920 elective activity, and as I mentioned, we're running at 112. In fact, as part of the replanning, systems have had their elective target reduced by 4% in recognition of the impact of the industrial action. And what that means is that we'll see more money flow into the ICB because, as I think we've reported previously, we're being paid on cost and volume for elective activity. So I'm really pleased to report that whilst we had a very challenging replanning round in terms of finances that I'm sure David will touch on shortly, we were able to be clear as a system that we would not reduce the volumes of elective activity that we were planning to deliver on the back of the financial constraints. I think industrial action has been our biggest trouble, and if I'm honest, I think trusts have been a bit nervous to plan that there'll absolutely be no further industrial action. Obviously, more news is flowing around that, but I think I feel, based on the last couple of weeks' levels of activity, increasingly confident that we'll see, continued progress on delivering reduced weights across the winter. Thanks.
Lovely, thank you very much, Liam.
Sarah Malik.
Thank you for that report, Jacqueline, which was very comprehensive. I think just keeping on the theme of industrial action and outcomes and the impact on health and social care systems, we currently have a transport strike in our area, and I have had feedback from my patients in the past couple of weeks that they've had to cancel appointments or not be able to attend appointments, which obviously will have a further impact on our health system in terms of backlog delivery, as well as NIAS impact as well. Do we have any early trajectory on whether there has been an impact, or will we be looking at that? Because obviously as a system, as an anchor organisation, that is something we have to mitigate for, isn't it?
Thanks, Sarah. I don't have any specific information on the kind of global impacts of that. It's been raised operationally, and I think some of the organisations have done some communications on it, to wit that if individual patients are concerned because of transport strikes that they can't make their appointment, they should contact the provider and reorganise rather than waiting till the appointment has passed. But obviously there will be occasions when people are not aware of the transport until the moment they need it not being there. So we'll have a look at that. I haven't picked up a huge impact, but obviously every patient who misses an appointment because of that sort of inconvenience or slot that we're not able to use is unfortunate.
Thank you. Mike Smith.
Thanks again for the report, Jacqueline. The information on waiting times for mental health services is somewhat startling and concerning. I'm looking at the data for secondary care for physical conditions. We currently have 9 patients waiting over 104 weeks, and we're in the thousands for mental health conditions, and that is worrying. I wonder whether we should include that as a core metric in our integrated performance delivery report going forward to show how, so that we can monitor that and also signify how important we consider that as a system.
Yeah, we're just doing a bit further work on some of those data to make sure they're absolutely spot on in terms of completeness and quality, but that would be the intention. Thanks.
Ken Bremner.
It's worth just reflecting for a second to you, Jacqueline, isn't it, that whilst we've got a large number of patients still waiting to get into our system, we still are the best performing system in the country on RTT, and that is by some measure. That's the time that people are waiting between referral and treatment. So although the numbers look quite large, both in terms of the waiting list and some of the times, we are still performing the best in the country on that RTT measure. It's not being officially measured, but it's still there in the background.
Thank you. Claire Riley.
Thank you, Chair. It was just in response to Sarah's challenge with regards to transport issues. I understand there has been a new deal put forward and is going to be balloted, so we are hopeful that actually the disruption will be sorted going forward.
Tom Hall.
Yeah, thanks. It was just to build on some of the comments of Sarah's as well around the potential for all these long waiters in particular to create even greater inequalities in access to health and care services. And schemes like the PIDMAS scheme, for example, where people are given opportunities to access services in different parts of the country, that's going to be accessible to people with means and resources to be able to support that, but not necessarily in some of our more deprived communities. So I guess it's just how we're watching out for that widening inequality across access to physical and mental health services in terms of long waits.
Sorry, Neil, do you want to add to that? Yes, okay, and then we'll take other questions.
Yeah, it's just to remind the board that we do have our Waiting Well project, which is still in operation, is going from strength to strength. That is focused on individuals who are on the P4 waiting list, to those who are